Welcome to NCLEX-ReviewPro, your trusted self-study toolkit for NCLEX preparation. In this Q&A session, we're tackling Obstetric/maternity nursing. Now, this is one of those sections where students often feel overwhelmed because there are so many topics: pregnancy, labor, postpartum, newborns. It feels like everything is connected. And honestly, it is. But here's the good news. On the NCLEX, OB is actually very pattern-based. If you understand the core priorities and safety rules, you can answer a huge percentage of questions correctly, even the difficult ones. So, in this series, we're not just going to memorize facts. We're going to train your clinical judgment. We're going to focus on what the test is really asking. And we're going to build that "I've seen this before" confidence. Here's how we've structured this entire OB section. We've broken it down into 6 high-yield sections, and we've carefully distributed 35 high-yield questions across these areas. Prenatal assessment, 6 questions. High-risk pregnancy, 8 questions. Labor and fetal monitoring, 6 questions. Labor emergencies, 6 questions. Postpartum, 5 questions. Newborn, 4 questions. So everything you need for OB is covered, not randomly, but in a way that actually mirrors how NCLEX tests you. As we go through each question, remember, always ask yourself, what is the priority? What is the risk to the mother or baby? And what is the safest action right now? Because in OB, 2 patients are involved, and safety is everything. All right, let's start building your OB confidence. Let's begin with our first section, Antepartum Care and Prenatal Assessment. Question 1, multiple choice. All right, let's break this down. We have a client coming in for her first prenatal visit after a positive home pregnancy test. Her last menstrual period was 5 weeks ago. The nurse is explaining which assessments are typically done at this visit. And the question is asking, which assessment would most likely not be completed at this time? Let's look at the options. Option A, calculation of body mass index, BMI. Option B, assessment for edema in the hands, face, and ankles. Option C, Doppler assessment of fetal heart tones. Option D, pelvic examination to assess uterine size. Take a moment and think about your answer. The correct answer here is option C. Let's break down why this is correct. At 5 weeks of gestation, this is still very early pregnancy. Here's the key concept. Fetal heart tones using a Doppler are usually not detectable until about 10 to 12 weeks. So even though the pregnancy is confirmed, it is too early for a Doppler device to pick up fetal heart activity. That makes this assessment inappropriate at this time. Now, let's see why the other options are not correct. Option A, BMI calculation. This is a standard part of the initial prenatal visit. It helps guide appropriate weight gain, nutritional counseling, and risk identification for complications like gestational diabetes and hypertension. So this is expected. Option B, assessment for edema. Even though edema becomes more clinically significant later, especially when evaluating for preeclampsia, we still establish a baseline early. Baseline findings are important for comparison as the pregnancy progresses, so this is also appropriate. Option D, pelvic examination. This is commonly performed during the initial prenatal visit. It helps assess uterine size, confirm intrauterine pregnancy, and allows for screening tests if needed, so this is expected as well. Here's your NCLEX alert. When you see early pregnancy questions, always think about timing. Doppler detects fetal heart tones at about 10 to 12 weeks. Fetoscope is later, around 18 to 20 weeks. Ultrasound can detect cardiac activity much earlier, around 6 weeks. So if the question is about early confirmation, ultrasound is your best answer, not Doppler. So the key takeaway here is this. Always match the intervention with the gestational age. If it is too early physiologically, it will not be the correct answer. This concept shows up again in scenarios where a patient is worried and says, "Why can't you hear my baby's heartbeat yet?" The correct response is reassurance, not escalation, because at 5 weeks, that is completely expected. Now let's move on to the next question. Question 2. Select all that apply. All right, let's break this down. We have a pregnant client at 34 weeks gestation undergoing routine antepartum fetal surveillance. The nurse is reviewing 2 tests, a non-stress test, NST, and a contraction stress test, CST. And the question is asking, which findings would indicate a need for further evaluation or follow-up? Let's look at the options. Option A, contraction stress test result is negative. Option B, non-stress test result is reactive. Option C, contraction stress test result is positive. Option D, non-stress test result is non-reactive. Take a moment and think about your answer. Remember, this is SATA, so more than one option may be correct. The correct answers here are option C and option D. Let's break down why these are correct. Option C, positive contraction stress test. A positive CST means that late decelerations occur during contractions, and this is the key concern. Late decelerations are associated with uteroplacental insufficiency, which means the fetus may not be getting enough oxygen during contractions. So this is a non-reassuring finding, and it requires further evaluation, possibly even planning for delivery depending on the situation. Option D, non-reactive NST. A non-reactive NST means the fetal heart rate is not showing expected accelerations with movement. Now, this could be due to several reasons. The fetus may be sleeping, there could be central nervous system depression, or, more concerning, fetal hypoxia. Because we cannot assume it is benign, this finding requires follow-up testing, such as a biophysical profile or repeat NST. Now let's see why the other options are not correct. Option A, negative CST. This is actually a good sign. A negative CST means there are no late decelerations during contractions, which suggests adequate uteroplacental circulation and good fetal oxygenation, so no follow-up is needed. Option B, reactive NST. This is also reassuring. A reactive NST means the fetus is showing appropriate accelerations in heart rate with movement, indicating good oxygenation and neurologic function. Again, no follow-up required. Here's your NCLEX alert. You need to memorize this pattern. NST, reactive is reassuring. CST, negative is reassuring. Now flip that. Non-reactive NST and positive CST. These are red flags. These require further evaluation. So the key takeaway here is this. Reactive NST means normal fetal oxygenation. Negative CST means reassuring uteroplacental circulation. Positive CST means late decelerations, which signal possible fetal compromise. And a non-reactive NST always requires further testing, such as a biophysical profile. Now, let's expand this a little further. Students often confuse NST and CST because both involve fetal heart monitoring. But here's the difference. NST looks at how the fetal heart responds to movement. CST looks at how the fetus tolerates contractions. So one is testing everyday activity. The other is essentially simulating labor. And that's why a positive CST is more concerning. It tells you the fetus may not tolerate labor well. Now let's build on this concept in the next question. Question 3. Ordered response. All right, let's break this down. We have multiple clients presenting to a women's health clinic, and the nurse needs to decide who to assess first. So this is a prioritization question. And the question is asking, place the following clients in order from highest priority to lowest priority. Let's look at the clients. Option A, client at 9 weeks gestation reporting severe nausea and vomiting for the past 6 hours. Option B, client at 37 weeks gestation with twins reporting irregular contractions. Option C, client whose last menstrual period was 7 weeks ago, reporting severe pelvic pain. Option D, primi gravida client at 19 weeks gestation who reports she has not yet felt fetal movement. Take a moment and think about your order. Remember, we are prioritizing based on risk and urgency. The correct order here is option C, then A, then B, then D. Let's break this down step by step. First, this client is about 7 weeks pregnant and is reporting severe pelvic pain. This is your highest priority. Why? Because in early pregnancy, severe pelvic or abdominal pain should immediately make you think of ectopic pregnancy, and this is a life-threatening condition. If it ruptures, it can lead to internal hemorrhage, hypovolemic shock, and maternal death. So, maternal safety is the priority here, and this client must be assessed first. Next, we should attend. This client is 9 weeks pregnant with severe nausea and vomiting. This could indicate hyperemesis gravidarum. Now, this is serious. It can lead to dehydration, electrolyte imbalance, and weight loss. But it is not as immediately life-threatening as a possible ruptured ectopic pregnancy, so this comes second. Then the nurse should attend. This client is 37 weeks pregnant with twins and reporting irregular contractions. At this stage, irregular contractions are often Braxton-Hicks contractions. They are uncomfortable, but not necessarily dangerous. This client does need assessment, but there is no immediate indication of a life-threatening condition, so this comes third. Finally, option D, a primi gravida at 19 weeks who has not yet felt fetal movement. This may sound concerning at first, but this is actually within normal expectations. Quickening in first pregnancies often occurs between 18 and even up to 22 weeks, so this is the lowest priority. Here's your NCLEX alert. When you are prioritizing OB questions, always remember this rule. Maternal life-threatening conditions come before fetal concerns, and early pregnancy with severe pelvic pain should always make you think ectopic pregnancy until proven otherwise. So the key takeaway here is this. Severe pelvic pain in early pregnancy is a red flag for ectopic pregnancy and requires immediate assessment, while hyperemesis gravidarum can cause dehydration but is usually not immediately life-threatening. Irregular contractions near term are often Braxton-Hicks and lower priority, and absence of fetal movement at 19 weeks in a first pregnancy can still fall within normal expectations of quickening. NCLEX tips. Prioritization questions in OB almost always come down to recognizing instability. Ask yourself, who is at risk of rapid deterioration? Not who is uncomfortable, not who is anxious, but who could crash first. And in OB, that is often tied to bleeding, pain in early pregnancy, or signs of hypoxia. Let's build on this concept in the next question. Question 4, multiple choice. All right, let's break this down. We have a 15-year-old primi gravida client at 16 weeks gestation coming in for a prenatal visit. The nurse is preparing education about healthy pregnancy practices, and the question is asking, which teaching should the nurse prioritize at this time? Let's look at the options. Option A, increase dietary iron intake. Option B, learn about the benefits of breastfeeding. Option C, attend all scheduled prenatal visits. Option D, recognize signs and symptoms of preeclampsia. Take a moment and think about your answer. The correct answer here is option A. Let's break down why this is correct. At 16 weeks, the client is in the second trimester, and here's the key physiologic change. Maternal blood volume is increasing significantly to support fetal growth. As blood volume expands, the demand for hemoglobin increases, and that means the demand for iron increases. If iron intake is not adequate, the client is at risk for iron deficiency anemia, which can affect both maternal energy levels and fetal oxygen delivery. So at this stage, increasing dietary iron intake becomes a priority teaching point. Now let's see why the other options are not correct. Option B, benefits of breastfeeding. This is important, but it is not the priority at 16 weeks. Breastfeeding education is usually emphasized later in pregnancy, closer to delivery when the client is preparing for newborn care. Option C. Attend all scheduled prenatal visits. This is absolutely important, but it is general teaching that applies throughout pregnancy. The question is asking for what should be prioritized right now, and this does not address an immediate physiologic need. Option D. Signs and symptoms of preeclampsia. Also important, but typically emphasized later in pregnancy, especially in the third trimester when the risk increases. At 16 weeks, it is not the most urgent teaching point. Here's your NCLEX alert. You should know the key nutrients in pregnancy and why they matter. Iron prevents maternal anemia. Folic acid prevents neural tube defects. Calcium supports fetal bone development. Protein supports overall fetal growth. And remember, iron requirements increase significantly during the second trimester. So the key takeaway here is this. Maternal blood volume increases during pregnancy, which increases the risk of iron deficiency anemia, and this is why iron requirements rise most during the second trimester, making nutrition teaching, especially iron intake, a priority at this stage of prenatal care. On the NCLEX, when you see a question asking for priority teaching, always think about what is happening physiologically at that exact stage of pregnancy. Not what is generally important, not what will be important later, but what the body needs right now. And in the second trimester, that answer is often tied to increased blood volume and nutritional demands. Now let's build on this concept in the next question. Question 5. Matrix. All right, let's break this down. We have a nurse teaching a prenatal class about the functions of the placenta during pregnancy. And the question is asking, for each statement, determine whether the placenta performs the function or does not perform the function. Let's go through each statement one by one. Facilitates oxygen exchange between maternal and fetal circulation. This is correct. The placenta does perform this function. Oxygen diffuses from maternal blood into fetal circulation through the placental membrane, which is essential for fetal oxygenation. Transfers nutrients such as glucose and amino acids to the fetus. Also correct. The placenta does perform this function. It transports key nutrients like glucose, amino acids, and fatty acids to support fetal growth and metabolism. Directly mixes maternal and fetal blood circulation. This is incorrect. The placenta does not perform this function. Maternal and fetal blood normally remain separate. Exchange happens across a membrane, not by direct mixing. Removes fetal metabolic waste products such as carbon dioxide. Correct. The placenta does perform this function. Waste products like carbon dioxide, urea, and bilirubin are transferred from the fetus into maternal circulation for elimination. Produces insulin to regulate maternal blood glucose levels. This is incorrect. The placenta does not perform this function. Insulin is produced by the pancreas, not the placenta. Here's your NCLEX alert. One of the most important concepts to remember is that maternal and fetal blood do not mix. All exchange occurs across the placental membrane through diffusion and transport mechanisms. So the key takeaway here is this. The placenta performs essential functions including oxygen exchange, nutrient transfer, and removal of fetal waste products, while also producing important pregnancy hormones such as HCG, progesterone, estrogen, and human placental lactogen to maintain pregnancy, but it does not allow direct mixing of maternal and fetal blood and does not produce hormones like insulin that are normally made by other organs such as the pancreas. Now, let's move on to the next question. Question 6. Drop down. All right, let's break this down. During a routine prenatal assessment, the nurse measures the client's fundal height and notes that the top of the uterus is located at the level of the umbilicus. The nurse should estimate the gestational age to be approximately blank weeks. Drop-down options: 16 weeks, 20 weeks, 24 weeks, 28 weeks? Take a moment and think about your answer. The correct answer here is 20 weeks. Let's break down why this is correct. Fundal height follows very predictable anatomical landmarks during pregnancy. At around 20 weeks gestation, the uterine fundus reaches the level of the umbilicus. So when you see fundus at the umbilicus, you should immediately think 20 weeks. Now let's quickly go through the other options. 16 weeks would place the fundus midway between the symphysis pubis and the umbilicus, so that is too low. 24 weeks and 28 weeks would place the fundus above the umbilicus, so those are too high. Here's your NCLEX alert. After 20 weeks, fundal height in centimeters roughly equals gestational age in weeks. So if you see something like 24 centimeters, you should think about 24 weeks. If you see 30 centimeters, think about 30 weeks. But before 20 weeks, you rely more on anatomical landmarks like the symphysis pubis and the umbilicus. So the key takeaway here is this. Fundal height is an important prenatal assessment tool, and when the fundus is at the level of the umbilicus, it corresponds to approximately 20 weeks gestation, after which fundal height in centimeters generally matches gestational age in weeks, while measurements before 20 weeks rely more on anatomical landmarks, and any significant discrepancy in expected fundal height may require further evaluation for conditions like growth restriction, excess fluid, or multiple gestation. Now let's move on to the next question. Now we're moving into Section 2, High-Risk Pregnancy and Antepartum Complications. This is where the NCLEX really starts testing your ability to recognize danger early. These questions are less about routine care and more about identifying what can go wrong, what is life-threatening, and what requires immediate action. So as we go through this section, keep your focus on red flags, maternal safety, and early intervention. Let's get into it. Question 7. Select all that apply. All right, let's break this down. We have a pregnant client at 32 weeks gestation presenting with new symptoms and the nurse suspects preeclampsia. And the question is asking, which assessment findings would support this diagnosis? Let's look at the options. Option A, anemia. Option B, epigastric pain. Option C, headache with blurred vision. Option D, frequent urination. Option E, proteinuria. Take a moment and think about your answer. Remember, this is SAT, so more than one option may be correct. The correct answers here are Option B, Option C, and Option E. Let's look into the rationale behind correct options Option B, epigastric pain. This is a very important warning sign. Epigastric or right upper quadrant pain can indicate liver involvement, often due to stretching of the liver capsule or hepatic ischemia. This is considered a severe feature of preeclampsia and may signal progression toward HELP syndrome or even eclampsia. Option C, headache with blurred vision. These are classic neurologic symptoms. They occur due to cerebral edema and vasospasm. When you see persistent headache or visual disturbances in a pregnant client, you should immediately think worsening preeclampsia and risk for seizures. Option E, proteinuria. This is one of the hallmark diagnostic findings. It occurs because hypertension damages the glomerular filtration barrier, allowing protein to leak into the urine. So this directly supports the diagnosis. Now let's see why the other options are not correct. Option A, anemia. Anemia is not a typical diagnostic feature of preeclampsia. You may see hemoconcentration, but anemia itself does not point toward this condition. Option D, frequent urination. This is very common in pregnancy due to uterine pressure on the bladder. It is not related to preeclampsia. Here's your NCLEX alert. You need to recognize the classic warning signs of severe preeclampsia: persistent headache, visual disturbances, epigastric or right upper quadrant pain, proteinuria, and severe hypertension. These are red flags and require immediate evaluation. So the key takeaway here is this. Preeclampsia involves hypertension with organ dysfunction, and the presence of neurologic symptoms such as headache and visual changes indicates cerebral involvement. Epigastric pain suggests possible liver injury or progression to HELP syndrome, and proteinuria remains a classic diagnostic marker, all of which signal worsening disease that requires prompt recognition and intervention. Now let's move on to the next question. Question 8. Select all that apply. All right, let's break this down. We have a client at 35 weeks gestation with severe preeclampsia who is receiving 1,5 magnesium sulfate for seizure prophylaxis. And the question is asking, which findings would indicate that the client is developing magnesium sulfate toxicity? Let's look at the options. Option A, absent patellar reflex. Option B, blood pressure of 156/84 millimeters of mercury. Option C, urine output of 600 milliliters in 8 hours. Option D, respiratory rate of 10 breaths per minute. Option E, serum magnesium level of 8.0 milliequivalents per liter. Take a moment and think about your answer. The correct answers here are Option A and Option D. Let's break down why these are correct. Option A, absent patellar reflex. This is one of the earliest and most important signs of magnesium toxicity. Magnesium suppresses neuromuscular activity, so as levels rise, reflexes begin to disappear. That is why checking deep tendon reflexes is a critical part of monitoring. Option D, respiratory rate of 10. This is a major red flag. Magnesium toxicity can depress the respiratory center. Any respiratory rate below 12 breaths per minute is concerning and can progress to respiratory arrest if not addressed immediately. Now let's see why the other options are not correct. Option B, blood pressure of 156/84. This reflects ongoing hypertension, which is expected in preeclampsia. Magnesium sulfate does not treat blood pressure. It is used to prevent seizures. Option C, urine output of 600 milliliters in 8 hours. This equals about 75 milliliters per hour, which is adequate. Magnesium is excreted by the kidneys, so toxicity risk increases when urine output drops below 30 milliliters per hour, not when it is normal. Option E, serum magnesium level of 8.0 milliequivalents per liter. This may be slightly above the therapeutic range, but toxicity is determined primarily by clinical findings, not lab values alone. On the NCLEX, always prioritize what you see clinically over isolated lab numbers. Here's your NCLEX alert. Classic signs of magnesium sulfate toxicity include absent deep tendon reflexes, respiratory rate less than 12, decreased urine output, and altered level of consciousness. And you must know the antidote: calcium gluconate. So the key takeaway here is this. Magnesium sulfate is used to prevent eclamptic seizures, but it requires close monitoring because rising levels suppress neuromuscular and respiratory function, making loss of reflexes and respiratory depression the earliest and most critical signs of toxicity, while adequate urine output helps prevent accumulation since magnesium is cleared by the kidneys, and calcium gluconate must be readily available as the antidote in case toxicity develops. Now let's move on to the next question. Question 9. Matrix. All right, let's break this down. We have pregnant clients presenting with vaginal bleeding in the 3rd trimester, and the question is asking, which findings are associated with placenta previa and which are associated with Abruptio placentae? Let's go through each finding one by one. Bright red, painless vaginal bleeding. This is placenta previa. This is the classic presentation. Painless bleeding, bright red, and often sudden. Severe abdominal pain. This is Abruptio placentae. Pain is a key differentiator here. Uterine tenderness. Also Abruptio placentae. The uterus becomes irritated and tender due to placental separation. Soft, relaxed uterus. This is placenta previa. The uterus remains soft because there is no irritation or separation occurring within the uterine wall. Board-like rigid abdomen. This is Abruptio placentae. This is a major red flag. The uterus becomes firm and rigid due to concealed bleeding and irritation. Here's your NCLEX alert. This is one of the most commonly tested OB comparisons, so you need a fast way to recognize it under pressure. Placenta previa is painless, with bright red bleeding and a soft uterus. Abruptio placentae is painful, often with darker bleeding, uterine tenderness, and a rigid or board-like abdomen. Now here are some exam tips. If you see the word painless, think placenta previa immediately. If you see pain or rigid abdomen, go straight to Abruptio placentae. Also, if the question mentions fetal distress early, that points more toward abruption. And one more high-yield safety rule. If placenta previa is suspected, never perform a vaginal exam because it can trigger severe hemorrhage. So the key takeaway here is this. Placenta previa presents with painless, bright red bleeding and a soft uterus due to placental placement over the cervical opening, while Abruptio placentae presents with painful bleeding, uterine tenderness, and a rigid abdomen due to premature placental separation, making pain versus no pain the fastest and most reliable way to differentiate between these two conditions on the NCLEX. Now let's move on to the next question. Question 10. Highlight the text. All right, let's break this down. We have a client in the 3rd trimester presenting with vaginal bleeding, and placenta previa is suspected. The nurse is reviewing provider orders, and the question is asking, which order should the nurse question? Let's look at the orders. Prepare the client for an ultrasound examination. Obtain equipment for a manual pelvic examination. Prepare to draw hemoglobin and hematocrit blood samples. Obtain equipment for external electronic fetal heart rate monitoring. Take a moment and think about your answer. The correct answer here is obtain equipment for a manual pelvic examination. Let's break down why this is correct. In suspected placenta previa, the placenta may be covering the cervical os. If you perform a manual or digital pelvic exam, you can disrupt the placenta, and that can lead to massive hemorrhage, putting both the mother and the fetus at immediate risk. So this is not just incorrect, this is dangerous. And this is exactly the type of order the nurse must question. Now let's see why the other options are not correct. Prepare the client for an ultrasound. This is appropriate. Ultrasound is the diagnostic test of choice to confirm placenta previa and determine placental location. Prepare to draw hemoglobin and hematocrit. Also appropriate. This helps assess the extent of blood loss and the client's hemodynamic status. Obtain equipment for external fetal monitoring. This is also correct. Placenta previa can affect fetal oxygenation, so continuous monitoring is important. Here's your NCLEX alert. This is a very high-yield safety rule. If placenta previa is suspected, never perform a vaginal or pelvic exam until it is ruled out by ultrasound. On the exam, anytime you see 3rd trimester bleeding plus a vaginal exam, that should immediately trigger a red flag. And here's another key exam tip. The nurse is the final safety checkpoint. If an order is unsafe, you do not carry it out, you question it. So the key takeaway here is this. Placenta previa presents with painless, bright red bleeding due to placental placement over or near the cervical os. And because of this location, any digital or manual pelvic examination is contraindicated until diagnosis is confirmed with ultrasound, since cervical manipulation can cause severe hemorrhage, and the nurse has a professional responsibility to recognize unsafe orders, withhold the action, and notify the provider while continuing appropriate care such as monitoring labs and fetal status. Now let's move on to the next question. Question 11. Highlight the text. All right, let's break this down. We have a client at 32 weeks gestation who says, "I think my water broke about an hour ago." So the nurse is preparing to evaluate whether the membranes have actually ruptured. And the question is asking, Which procedure is used to confirm rupture of membranes? Let's look at the options. Perform a digital vaginal examination. Perform an ultrasound. Perform a Fern test. Obtain a Group B Streptococcus culture. Take a moment and think about your answer. The correct highlight the text here is perform a Fern test. Let's break down why this is correct. A Fern test is specifically used to confirm rupture of membranes. Here's how it works. A sterile speculum exam is performed. Vaginal fluid is collected and then placed on a slide. When viewed under a microscope, amniotic fluid creates a characteristic fern-like crystallization pattern. If you see that pattern, it confirms the presence of amniotic fluid, meaning the membranes have ruptured. Now let's see why the other options are not correct. Perform a digital vaginal examination. This is incorrect and actually unsafe at this stage. If PROM is suspected, digital exams should be avoided because they increase the risk of ascending infection, especially in preterm cases like this one. Perform an ultrasound. Ultrasound can estimate amniotic fluid levels, but it cannot reliably confirm whether the membranes have ruptured, especially with small leaks. Obtain a Group B Streptococcus culture. This may be done after rupture is confirmed, but it does not diagnose PROM. Here's your NCLEX alert. When PROM is suspected, you must avoid digital vaginal exams. Instead, use a sterile speculum exam along with a Fern test or nitrazine test to confirm rupture. This is a major infection prevention principle and shows up frequently on the NCLEX. So the key takeaway here is this. PROM refers to rupture of membranes before labor begins, and confirmation is done using a sterile speculum exam with tests such as the Fern test, while digital vaginal examinations must be avoided until rupture is confirmed because they increase the risk of infection. And once PROM is confirmed, additional assessments like Group B Streptococcus cultures may be performed as part of ongoing care. Now let's move on to the next question. Question 12, multiple choice. All right, let's break this down. We have a client with preeclampsia who is reporting blurred vision and seeing spots. And the question is asking, which condition do these findings most strongly suggest? Let's look at the options. Option A, glaucoma. Option B, cerebral edema. Option C, spinal cord injury. Option D, hydrocephalus. Take a moment and think about your answer. The correct answer here is option B. Let's break down why this is correct. Visual disturbances such as blurred vision and scotomata are classic neurologic warning signs of severe preeclampsia. These symptoms occur due to cerebral vasospasm and swelling of brain tissue, which is cerebral edema. And this is not just a symptom, this is a warning. It tells you that the condition is progressing and the client is at risk for serious complications like seizures, stroke, or hypertensive crisis. Now let's see why the other options are not correct. Option A, glaucoma. This is related to increased pressure inside the eye. It is not associated with preeclampsia or these types of neurologic symptoms. Option C, spinal cord injury. This would cause motor and sensory deficits, not visual disturbances, so this does not match the presentation. Option D, hydrocephalus. This involves excess cerebrospinal fluid in the brain, but it does not present with the classic visual symptoms seen in preeclampsia. Here's your NCLEX alert. You need to recognize the warning signs of severe preeclampsia immediately. Severe headache, blurred vision or seeing spots, epigastric or right upper quadrant pain, hyperreflexia, and severe hypertension. These findings signal increased risk for eclampsia, which means seizures. And on the exam, when you see these symptoms, the priority is immediate reporting and intervention. So the key takeaway here is this. Visual disturbances in preeclampsia indicate neurologic involvement caused by cerebral edema and vasospasm, and these symptoms are not benign but represent progression towards severe disease with increased risk of seizures, which is why they require immediate recognition and prompt action. Now let's move on to the next question. Question 13, format bow tie. All right, let's break this down. We have a pregnant client at 30 weeks gestation with gestational diabetes, and her blood glucose levels are still elevated despite dietary counseling. So now the nurse is concerned about complications related to poor glycemic control. First, we identify the condition. The client has gestational diabetes mellitus. Now the question is asking us to select 2 likely fetal complications and 2 priority nursing interventions from the given options. Take a moment and think about your selections. The correct answers on the left side, fetal complications, are macrosomia, neonatal hypoglycemia. Let's break down why. When maternal blood glucose is high, that glucose crosses the placenta, so the fetus is exposed to elevated glucose levels. In response, the fetus produces more insulin. That extra insulin acts like a growth hormone, so the baby grows larger than normal. That is macrosomia. Now, after birth, the glucose supply from the mother suddenly stops, but the baby's insulin levels are still high, so blood sugar drops, and that leads to neonatal hypoglycemia. Now let's look at the right side, nursing interventions. The correct answers are monitor maternal blood glucose levels regularly, provide dietary counseling and glucose management education. These directly address the root problem, which is uncontrolled glucose. Monitoring helps track control. Dietary management helps correct it. Now let's briefly go through the incorrect options. Neural tube defects. These are associated with poor glucose control early in pregnancy, not typically a late 2nd or 3rd trimester complication like in this case. Placenta previa. This is related to placental placement, not glucose levels. Oligohydramnios. This is low amniotic fluid and is not a typical finding in gestational diabetes. Encourage strict bed rest. Not indicated and does not treat glucose imbalance. Administer magnesium sulfate. This is used for seizure prevention in preeclampsia, not for gestational diabetes. Restrict fluid intake. This is not appropriate and can be harmful. Here's your NCLEX alert. When you see gestational diabetes, you should immediately think macrosomia, and macrosomic infants are at risk for shoulder dystocia, birth trauma, and neonatal hypoglycemia. Also, always remember, in endocrine-related questions, the priority is to control the underlying imbalance. So the key takeaway here is this. Gestational diabetes represents impaired glucose tolerance during pregnancy, and when maternal glucose is not well controlled, it leads to fetal hyperinsulinemia, resulting in macrosomia before birth and neonatal hypoglycemia after birth, which is why nursing priorities focus on regular glucose monitoring and effective dietary management to maintain stable maternal glucose levels. Now let's move on to the next question. Question 14, multiple choice. All right, let's break this down. We have a pregnant client at 10 weeks gestation presenting with persistent nausea and vomiting for several days. She cannot keep food or fluids down, and her assessment shows dry mucous membranes, weight loss, and ketones in the urine. So the question is asking, which nursing action is the priority? Let's look at the options. Option A, encourage the client to eat small, frequent meals. Option B, administer oral antiemetic medication. Option C, initiate IV fluids with electrolyte replacement. Option D, provide dietary teaching about nausea triggers. Take a moment and think about your answer. The correct answer here is option C. Let's break down why this is correct. This client is showing clear signs of hyperemesis gravidarum, not just normal pregnancy nausea. We are seeing dehydration, weight loss, and ketonuria. That means the body is breaking down fat for energy due to lack of intake. At this point, the priority is not education, it is stabilization. The client needs IV fluids to restore hydration and correct electrolyte imbalance. Without that, the condition can worsen and affect both maternal and fetal health. Now let's see why the other options are not correct. Option A, small frequent meals. This is appropriate for mild nausea, but not when the client cannot tolerate any oral intake. Option B, oral antiemetics. These may be useful later, but right now the client cannot keep anything down, so oral medications are not effective. Option D, dietary teaching. Important, but not a priority when the client is already dehydrated. Here's your NCLEX alert. You should recognize the classic signs of hyperemesis gravidarum: persistent vomiting, weight loss, ketonuria, dehydration, and electrolyte imbalance. And here's the exam tip. When a question shows dehydration or instability, always think fluids first. On the NCLEX, fluids come before food, teaching, and oral medications. So the key takeaway here is this. Hyperemesis gravidarum is a severe form of pregnancy-related vomiting that leads to dehydration, electrolyte imbalance, and ketosis. And when these signs are present, the priority is immediate fluid and electrolyte replacement with IV therapy before any oral intake, medications, or teaching can be effective. And that brings us to the end of Section 2, High-Risk Pregnancy and Antepartum Complications. Now we move into the next phase where things become even more dynamic. Let's move into Section 3, Intrapartum Nursing and Fetal Monitoring. Intrapartum is the period during labor and childbirth, from the start of true contractions to delivery of the baby and placenta. NCLEX focus: monitor fetal heart rate and contractions. Keep in mind oxygenation plus priority interventions. Question 15, multiple choice. All right, let's break this down. We have a pregnant client experiencing infrequent, irregular, and non-painful uterine contractions that are not causing any cervical dilation. And the question is asking, how should the nurse document these contractions? Let's look at the options. Option A, true labor contractions. Option B, uterine tachysystole. Option C, Braxton-Hicks contractions. Option D, preterm labor contractions. Take a moment and think about your answer. The correct answer here is option C. Let's break down why this is correct. These are classic features of Braxton-Hicks contractions. They are irregular, mild, and do not cause any cervical change. They are essentially practice contractions as the uterus prepares for labor. You'll often see that they decrease with rest, hydration, or a change in position. So when you see irregular plus no dilation, think false labor. Now let's see why the other options are not correct. Option A, true labor contractions. True labor is very different. Those contractions are regular, get progressively stronger, and most importantly, they cause cervical dilation and effacement. Option B, uterine tachysystole. This refers to excessive contractions, usually more than 5 contractions in 10 minutes. This is typically related to oxytocin use, not normal pregnancy patterns. Option D, preterm labor contractions. Preterm labor involves regular contractions with cervical change before 37 weeks. That is not happening here. Here's your NCLEX alert. The exam loves testing the difference between false labor and true labor. If contractions are irregular, mild, and stop with rest, think Braxton-Hicks. If they are regular, increasing in intensity, and causing cervical change, think true labor. So the key takeaway here is this. Braxton-Hicks contractions are normal, irregular, and usually painless uterine contractions that occur during pregnancy as the uterus prepares for labor. And the most important distinction is that they do not cause cervical dilation and often resolve with rest or hydration, which helps you clearly differentiate them from true labor on the NCLEX. Now let's build on this concept as we move into true labor patterns and fetal monitoring. Question 16, matrix/grid. All right, let's break this down. Clinical scenario. A nurse in the labor and delivery unit is assessing several clients. Based on the assessment findings, determine which stage of labor each client is experiencing. We have multiple assessment findings, and we need to match each one to the correct stage of labor. So this is all about recognizing patterns and understanding what is happening physiologically. Let's go through each finding one by one. Cervix dilated 2 centimeters with mild irregular contractions. This corresponds to stage 1. This is early labor, also called the latent phase, where dilation begins and contractions are still mild and irregular. Cervix dilates from 6 centimeters to 8 centimeters with increasingly strong and frequent contractions, 100% effaced. This is still stage 1, specifically the active phase. At this point, contractions become stronger, more regular, and dilation progresses more rapidly. Cervix 9 to 10 centimeters dilated, contractions extremely strong, client reports rectal pressure. This is also stage 1, but now we are in the transition phase. This is the most intense part of stage 1. The key clue here is rectal pressure, which students often confuse with pushing. Cervix fully dilated to 10 centimeters with a strong urge to push. This is stage 2. Stage 2 begins once the cervix is fully dilated and ends with the delivery of the baby. The urge to push is your biggest clue here. Placenta separates and is expelled from the uterus. This is stage 3. This stage begins after the baby is delivered and ends with the delivery of the placenta. Here's your NCLEX alert. You must clearly distinguish between rectal pressure and the urge to push. Rectal pressure happens in late stage 1 during transition. The urge to push means you are in stage 2. This is a very common exam trap. So the key takeaway here is this. Labor is divided into stages, where stage 1 involves cervical dilation from 0 to 10 centimeters, progressing through latent, active, and transition phases. Stage 2 begins with full dilation and is marked by the urge to push and delivery of the baby, and stage 3 involves delivery of the placenta, and recognizing key cues like rectal pressure versus urge to push helps you accurately identify the correct stage on the NCLEX. Now let's continue building on this as we move into fetal monitoring and labor assessment. Question 17, multiple choice. All right, let's break this down. We have a client in active labor, and the nurse is reviewing fetal heart rate monitoring strips. And the question is asking, which image shows late decelerations, a pattern that suggests uteroplacental insufficiency and possible fetal hypoxia? Let's look at the options. Image 1, Image 2, Image 3, Image 4. Take a moment to review these graph images and think about your answer. This is a classic pattern recognition question, so focus on timing. The correct answer here is option C, Image 3. Let's break down how to recognize this. Late decelerations are all about timing in relation to the contraction. The deceleration begins after the contraction starts. The lowest point of the fetal heart rate happens after the peak of the contraction, and recovery occurs after the contraction ends. So the fetal heart rate is essentially lagging behind the contraction. That is your key clue. Cause: uteroplacental insufficiency. NCLEX teaching: non-reassuring pattern. Priority actions: reposition mother, oxygen, stop oxytocin, notify provider. Now, let's quickly walk through the other images so you can clearly differentiate them. Image 1 shows an acceleration. You'll see the baseline around 140 to 150 with an upward increase of at least 15 beats per minute lasting at least 15 seconds. This is reassuring. Accelerations mean the baby is well oxygenated. Think of them as good news. Image 2 shows early decelerations. Here, the fetal heart rate drop mirrors the contraction. It starts with the contraction, hits its lowest point at the peak, and recovers as the contraction ends. This is normal in labor and does not require intervention. Cause: fetal head compression. Interpretation. Normal during labor, checkmark. No intervention needed. Image 4 shows variable decelerations. These are abrupt V-shaped drops in fetal heart rate. They do not follow a consistent pattern with contractions. Cause is umbilical cord compression. Management usually involves repositioning the mother and sometimes amnio infusion. Now coming back to image 3, late decelerations. This is the one you must recognize immediately on the NCLEX, because this is a non-reassuring pattern. It indicates uteroplacental insufficiency, meaning the fetus is not getting enough oxygen. Here's your NCLEX alert. Always compare the fetal heart rate tracing with the contraction pattern. That relationship is everything. And here's a quick exam tip. Early equals equal. The dip mirrors the contraction. Late equals lagging. The dip happens after the contraction. Variable equals V-shaped. Abrupt drops anywhere. Accelerations equal reassurance. And if you see late decelerations, think hypoxia until proven otherwise. So the key takeaway here is this. Late decelerations are identified when the fetal heart rate decrease begins after the contraction starts, reaches its lowest point after the contraction peak, and recovers after the contraction ends, indicating uteroplacental insufficiency and possible fetal hypoxia, which makes this a concerning pattern that requires immediate nursing intervention. Now let's move to the next question. Question 18, ordered response. All right, let's break this down. We have a client in active labor, and the nurse observes recurrent late decelerations on the fetal heart rate monitor. So right away, you should be thinking, this is a non-reassuring pattern. The fetus may not be getting enough oxygen. And the question is asking, place the nursing interventions in the correct order of priority. Let's look at the interventions. Administer oxygen via face mask at 8 to 10 liters per minute. Reposition the client to a left lateral position. Increase the IV fluid rate. Discontinue oxytocin infusion. Notify the provider. Take a moment and think about your answer. Think in terms of restoring oxygen to the fetus as quickly as possible. The correct order is, first, reposition the client to the left lateral position. Second, discontinue oxytocin infusion. Third, increase the IV fluid rate. Fourth, administer oxygen via face mask. Fifth, notify the provider. Let's break down why this order matters. Before anything else, understand the physiology. Late decelerations are caused by uteroplacental insufficiency. That means decreased fetal oxygen delivery, leading to possible hypoxia. So every intervention you choose should improve oxygen delivery to the fetus. Step 1. Reposition the client. This is your fastest and most effective first action. Placing the client in a left lateral position relieves pressure on the vena cava, improves maternal circulation, and increases blood flow to the placenta. This directly improves fetal oxygenation. Step 2. Discontinue oxytocin. Oxytocin increases uterine contractions. Too many contractions reduce blood flow to the placenta. So stopping oxytocin removes that stress and helps restore oxygen delivery. Step 3. Increase IV fluids. This improves maternal circulating volume. Better volume means better placental perfusion and improved oxygen transport to the fetus. Step 4. Administer oxygen. This increases the amount of oxygen available in maternal blood for transfer to the fetus. It supports oxygenation, but it comes after circulation has been optimized. Step 5. Notify the provider. This is important, but only after you initiate immediate nursing interventions. If the pattern persists, further medical management may be required. Here's your NCLEX alert. When you see abnormal fetal heart rate patterns, your first move is almost always repositioning the client. And here's a high-yield exam tip. Do not jump to calling the provider before initiating nursing actions. On the NCLEX, you act first, then escalate. So the key takeaway here is this. Late decelerations indicate uteroplacental insufficiency and decreased fetal oxygen delivery. So the priority sequence of care focuses on immediately improving placental perfusion through repositioning, removing causes such as oxytocin, supporting circulation with IV fluids, enhancing oxygen delivery, and then notifying the provider if the pattern does not resolve. And here's a simple memory tip you can use on exam day. Position, stop oxytocin, fluids, oxygen, provider. Now let's continue building on this as we move into more advanced fetal monitoring and labor interventions. Question 19. Multiple choice. Clinical scenario. A nurse reviews the fetal monitor tracing from a contraction stress test, CST, performed to evaluate fetal tolerance to uterine contractions. Based on the tracing provided, which interpretations is correct? Review the graph. Let's look at the options. Option A. The tracing represents a positive CST result. Option B. The tracing indicates late decelerations occur with at least 50% of contractions. Option C. The test result suggests the fetus may not tolerate labor well. Option D. The tracing represents a negative CST result. Option E. The findings suggest uteroplacental insufficiency may be present. Take a moment and think about your answer. This question is all about recognizing whether late decelerations are present or not. The correct answer here is option D. Let's break down why this is correct. A negative CST is considered normal and reassuring. What does that mean? It means there are no late decelerations during contractions. The fetal heart rate remains stable even when the uterus contracts. That tells you the fetus is tolerating temporary decreases in blood flow during contractions without becoming hypoxic. So this is a good sign. Now let's go through the incorrect options. Option A, positive CST. This would mean late decelerations are present. That is not what we see here. Option B, late decelerations with at least 50% of contractions. That is actually the definition of a positive CST. Again, not seen in this tracing. Option C, fetus may not tolerate labor well. That would also point toward a positive CST, not a negative one. Option E, uteroplacental insufficiency. This is associated with late decelerations and a positive CST, not with a negative CST. Now let's quickly solidify this with a simple comparison. A negative CST means no late decelerations and is reassuring. A positive CST means late decelerations occur with at least 50% of contractions and is concerning. An equivocal CST means intermittent or inconsistent late decelerations and is inconclusive. Here's your NCLEX alert. CST questions are testing one thing. Do you see late decelerations or not? If there are no late decelerations, the answer is negative CST, and that is a good sign. If late decelerations are present, especially with half or more of contractions, that is a positive CST, and it is concerning. Now let's walk through how to read the graph. First, identify the contractions on the lower tracing. Second, look at the fetal heart rate on the top tracing. Third, check if the heart rate drops after the contractions. If there are no late decelerations, the CST is negative. So the key takeaway here is this. A negative contraction stress test means there are no late decelerations during contractions, indicating that the fetus is maintaining adequate oxygenation and can tolerate labor, whereas the presence of late decelerations would indicate a positive test and possible uteroplacental insufficiency. And here's a simple memory tip. Negative CST means no late decelerations, which is a good sign. Now let's move forward and build on this as we continue with fetal monitoring concepts. Question 20. Highlight the text. All right, let's break this down. A nurse in the maternity triage unit is assessing a multiparous client who arrived reporting contractions. And the question is asking, which statements indicate true labor? Let's look at the client's statements carefully. I started feeling contractions earlier today. At first, they were irregular, but now they seem to be coming closer together. The pain starts in my lower back and moves toward the front of my abdomen. Yesterday, I felt some tightening in my abdomen, but when I rested for a while, the discomfort seemed to ease. I also noticed that when I walked around, the contractions sometimes changed or slowed down. I tried walking around and resting this morning, but the contractions keep getting stronger and lasting longer. They also feel much more intense than the tightening I had earlier in pregnancy. Take a moment and identify the key phrases. The correct statements to highlight are: they seem to be coming closer together. The pain starts in my lower back and moves toward the front of my abdomen. The contractions keep getting stronger and lasting longer. Let's break down why these are correct. True labor follows a very specific pattern. There is increasing frequency, meaning contractions come closer together. There is increasing intensity, meaning they get stronger. And there is increasing duration, meaning they last longer. You also often see a characteristic pain pattern. It starts in the lower back and radiates to the abdomen. And importantly, true labor does not stop with rest or activity. So all three highlighted statements clearly reflect true physiologic labor. Now let's look at the other statements and why they are less diagnostic or reflect false labor. I started feeling contractions earlier today. This alone does not confirm true labor. Both true and false labor can begin with contractions. They also feel more intense than the tightening I had earlier in pregnancy. This can be misleading. Braxton Hicks contractions can sometimes feel stronger as pregnancy progresses, so this alone is not enough to confirm true labor. Now look at these key false labor clues. Yesterday, I felt some tightening in my abdomen, but when I rested, the discomfort eased. This is classic Braxton Hicks. False labor improves with rest. When I walked around, the contractions sometimes changed or slowed down. Again, this points to false labor. True labor continues regardless of movement. False labor often decreases with activity or position change. Here's your NCLEX alert. Memorize this rule for the exam. True labor equals 3 progressions: stronger, longer, closer together. And here's the high-yield clinical tip. If contractions continue despite rest or movement, assume true labor until proven otherwise. Let's anchor this with a quick comparison. False labor is irregular, often stops with rest, and usually causes abdominal discomfort without cervical change. True labor is regular, continues despite activity, causes pain that starts in the lower back and radiates forward, and leads to cervical dilation. So the key takeaway here is this. True labor is identified by contractions that progressively become stronger, longer, and closer together, often with pain radiating from the lower back to the abdomen and continuing despite rest or activity, whereas contractions that ease with rest or change with movement are more consistent with false labor, and recognizing this distinction is a classic and high-yield concept on the NCLEX. And that brings us to the end of Section 3, Intrapartum Nursing and Fetal Monitoring. Now we move into Section 4, Labor Emergencies. This is where the NCLEX tests how fast you can recognize danger and act. Think priority, think oxygenation, and think immediate intervention. Let's get into it. Question 21. Ordered response. All right, let's break this down. We have a laboring client, and during a vaginal exam, the nurse identifies that the umbilical cord is protruding from the vagina. The fetal monitor shows recurrent variable decelerations. This is umbilical cord prolapse, a true obstetric emergency. And the question is asking, place the nursing interventions in the correct order of priority. Let's look at the interventions. Administer oxygen at 8 to 10 liters per minute via face mask. Prepare the client for emergency cesarean delivery. Call for assistance and notify the healthcare provider. Insert a sterile, gloved hand and elevate the presenting fetal part. Place the client in Trendelenburg or knee-chest position. Take a moment and think about your answer. This is a high-stakes prioritization question. The correct order is: first, call for assistance and notify the healthcare provider. Second, insert a sterile gloved hand and elevate the presenting fetal part. Third, place the client in Trendelenburg or knee-chest position. Fourth, administer oxygen via face mask. Fifth, prepare the client for emergency cesarean delivery. Now let's break down the clinical reasoning. Umbilical cord prolapse occurs when the cord slips ahead of the presenting fetal part and becomes compressed between the fetus and the maternal pelvis. This leads to decreased blood flow through the cord, which rapidly causes fetal hypoxia and fetal distress. So your priorities are very clear. Activate the emergency team, relieve cord compression, improve oxygenation, prepare for rapid delivery. Let's go step by step. Step 1. Call for assistance and notify the provider. This is a true emergency. You cannot manage this alone. You need the obstetric provider, anesthesia team, and operating room ready immediately. If you delay calling for help, you are stuck holding the presenting part while time is running out. Step 2. Insert a sterile gloved hand and elevate the presenting fetal part. This is the most critical life-saving action. You physically lift the fetus off the cord. This relieves compression, restores blood flow, and improves fetal oxygen delivery. Step 3. Position the client. Trendelenburg or knee-chest position uses gravity to move the fetus away from the cord. This further reduces compression. Step 4. Administer oxygen. Giving 8 to 10 liters per minute increases maternal oxygen levels and improves placental oxygen transfer. Step 5. Prepare for emergency cesarean delivery. Cord prolapse almost always requires rapid delivery unless birth is imminent. Now here's a very important NCLEX strategy insight. You may see two possible first actions in these questions: call for help or relieve compression with your hand. Which one is correct depends on how the question is worded. If the question emphasizes emergency response, calling for help may come first. If it focuses on immediate physiologic intervention, then inserting the gloved hand is the priority. In real practice, you often do both at the same time. You call for help while performing the maneuver. Here's why the NCLEX tests this. Cord prolapse causes. Cord compression leads to decreased fetal oxygen, leading to hypoxia. The only action that immediately restores oxygen flow is lifting the presenting part. Calling the provider does not fix oxygenation. Here's your NCLEX alert. Never attempt to push the cord back into the vagina. This can cause vasospasm and worsen fetal oxygen deprivation. And remember this sequence: relieve compression, position the mother, give oxygen, prepare for emergency delivery. Also, if another nurse is present, have them call the provider while you stay with the patient. You do not leave the bedside. So the key takeaway here is this: umbilical cord prolapse is a life-threatening emergency that causes acute fetal hypoxia, and management requires immediate team activation along with rapid decompression of the cord by elevating the presenting fetal part, followed by positioning, oxygenation, and preparation for emergency delivery, with the understanding that relieving compression is the only intervention that directly restores fetal circulation. Now let's continue as we move deeper into labor emergencies. Question 22, multiple choice. Let's see the clinical scenario. During a vaginal delivery, the fetal head is delivered but retracts tightly against the perineum and the shoulders fail to deliver despite gentle traction. The nurse recognizes this finding as shoulder dystocia. And the question is asking, which nursing action should the nurse anticipate assisting with first? Let's look at the options. Option A, apply fundal pressure to help deliver the shoulders. Option B, perform the McRoberts maneuver by hyperflexing the mother's legs to the abdomen. Option C, attempt manual rotation of the fetal shoulders. Option D, prepare the client for emergency cesarean birth. Take a moment and think about your answer. This is a high-priority obstetric emergency. The correct answer here is option B, perform the McRoberts maneuver. Let's see the clinical reasoning. Shoulder dystocia occurs when the fetal anterior shoulder becomes impacted behind the maternal pubic symphysis after the head has delivered. This creates an emergency because the umbilical cord can become compressed, leading to rapid fetal hypoxia. So the goal is simple. You need to free the shoulder immediately. The first-line intervention is the McRoberts maneuver. This involves hyperflexing the mother's legs tightly toward the abdomen. What does this do? It straightens the sacrum, rotates the pubic symphysis, and widens the pelvic outlet. And in many cases, this alone is enough to release the impacted shoulder. Now let's see why the other options are not correct. Option A, apply fundal pressure. This is contraindicated. Fundal pressure pushes the fetus downward and can worsen the impaction. It also increases the risk of uterine rupture and fetal injury. Option C, attempt manual rotation. These are internal maneuvers like the Wood's screw maneuver. They may be used if McRoberts and suprapubic pressure do not work, but they are not the first step. Option D, prepare for emergency cesarean birth. This is not appropriate at this stage. The fetal head is already delivered. You cannot perform a cesarean at this point. You must resolve the dystocia vaginally using maneuvers. Here's your NCLEX alert. Shoulder dystocia is a must-know emergency, and there is one rule you must never forget. Never apply fundal pressure. Instead, think McRoberts first. So the key takeaway here is this. Shoulder dystocia occurs when the fetal shoulder becomes impacted behind the pubic symphysis after head delivery, and the first-line intervention is the McRoberts maneuver, which widens the pelvic outlet and helps release the shoulder, while fundal pressure is contraindicated because it worsens the obstruction and increases the risk of injury. Now let's continue building on labor emergencies and how to respond effectively. Question 23, matrix/grid. All right, let's break this down. We're looking at medications used during labor and obstetric emergencies, and this question is testing two things at the same time. First, what each medication is used for, and second, the most important safety risk you need to monitor. So before we jump into answers, let's clearly understand both tables. With most important OB medications, oxytocin, magnesium sulfate, terbutaline, and methylergonavine. The first table is about indications. For each medication, you need to identify what it is primarily used for. Is it used to control postpartum hemorrhage? Is it used to stop preterm contractions? Or is it used to prevent eclamptic seizures? The second table is about safety. Now we're matching each medication to its biggest danger. Do you need to monitor for respiratory depression, maternal tachycardia, uterine tachysystole, or is the medication contraindicated in hypertension? So this question is combining purpose plus risk. That's exactly how the NCLEX tests pharmacology, not just what the drug does, but what can go wrong. Now let's go through each medication one by one. First, oxytocin. Oxytocin is used to control postpartum hemorrhage. It works by stimulating uterine contractions, especially in cases of uterine atony. But here's the safety concern. Oxytocin can cause uterine tachysystole. Too many contractions can reduce placental blood flow and lead to fetal hypoxia. Next, magnesium sulfate. This is used to prevent seizures in preeclampsia and eclampsia, so its role is neurologic protection. But magnesium depresses the central nervous system, so the biggest danger is respiratory depression. You must monitor respirations and reflexes closely. Next, terbutaline. Terbutaline is a tocolytic. It relaxes uterine smooth muscle and is used to stop preterm contractions. But because it stimulates beta receptors, it can increase heart rate. So the key safety concern is maternal tachycardia. Finally, methylergonavine. This medication is used to control postpartum hemorrhage by causing strong, sustained uterine contractions. But it also causes vasoconstriction, so it is contraindicated in clients with hypertension, because it can trigger a hypertensive crisis. Now, let's anchor this with a quick pairing. Oxytocin, postpartum hemorrhage, watch for uterine tachysystole. Magnesium sulfate, seizure prevention, watch for respiratory depression. Terbutaline, stops contractions, watch for maternal tachycardia. Methylergonavine, postpartum hemorrhage, avoid and hypertension. Here's your NCLEX alert. Always associate these drug danger pairs. Magnesium sulfate equals respiratory depression. Terbutaline equals tachycardia. Oxytocin equals uterine tachysystole. Methylergonavine equals hypertension risk. If you memorize these pairs, you will answer these questions quickly. So the key takeaway here is this. In obstetric emergencies, it is not enough to know what a medication is used for. You must also recognize its most dangerous side effect, because early identification of toxicity or adverse effects is critical to preventing maternal and fetal complications on the NCLEX. Now let's continue building on obstetric emergencies and high-risk interventions. Question 24. Bow tie. All right, let's break this down. We have a client with a history of a previous cesarean birth who is in active labor and receiving oxytocin for induction. During labor, the client suddenly reports sharp abdominal pain that persists between contractions. And now we see multiple concerning findings. Sudden fetal bradycardia on the monitor, loss of fetal station, maternal abdominal tenderness, vaginal bleeding. The nurse suspects uterine rupture. So in this bow tie question, we need to identify three things: the contributing factors on the left, the priority condition in the center, and the priority nursing interventions on the right. Take a moment and think about your selections. Let's start with the contributing factors. The correct answers are previous cesarean uterine scar, oxytocin stimulation of labor. Now let's break down why. A previous cesarean scar is the biggest risk factor. That scar creates a weak point in the uterine wall, and during labor, especially with strong contractions, that area can tear. Oxytocin increases contraction strength and frequency, so if the uterus is already weakened by a scar, oxytocin increases the stress on that wall and raises the risk of rupture. Now let's briefly rule out the incorrect options. Placenta previa causes painless vaginal bleeding, not uterine rupture. Umbilical cord compression causes variable decelerations, not this full clinical picture. Now moving to the center, the priority condition is uterine rupture. This is a catastrophic event. The uterine wall tears, and the fetus may partially or completely move into the abdominal cavity. This leads to acute fetal hypoxia and maternal hemorrhage. Now let's move to the priority interventions. The correct answers are: stop oxytocin infusion, prepare for emergency cesarean birth. Let's break this down. Stopping oxytocin is immediate. You need to reduce uterine stimulation right away to prevent further tearing. Preparing for emergency cesarean birth is critical. This is a surgical emergency. The fetus must be delivered immediately to prevent fetal death and severe maternal complications. Now let's rule out the incorrect interventions. Fundal massage is used for postpartum hemorrhage due to uterine atony, not rupture. Encouraging pushing increases intrauterine pressure and can worsen the rupture. Here's your NCLEX alert. The earliest and most common sign of uterine rupture is sudden fetal heart rate abnormality, especially fetal bradycardia. If you see sudden fetal distress combined with abdominal pain and loss of station, think uterine rupture immediately. So the key takeaway here is this. Uterine rupture is a life-threatening obstetric emergency most commonly associated with a previous cesarean scar and increased uterine stress from oxytocin, and it presents with sudden fetal distress and maternal symptoms requiring immediate discontinuation of oxytocin and rapid preparation for emergency cesarean delivery to prevent fetal hypoxia and maternal hemorrhage. Now let's continue as we move through the final obstetric emergencies. Question 25, multiple choice. All right, let's break this down. We have a client who delivered a healthy newborn 20 minutes ago, and now the nurse observes some very concerning findings. Heavy vaginal bleeding, a boggy uterus above the umbilicus, a saturated perineal pad within 10 minutes, and a maternal pulse of 118 per minute. So the question is asking, which nursing action should the nurse perform first? Let's look at the options. Option A, Notify the obstetric provider. Option B. Administer oxytocin as prescribed. Option C. Massage the uterine fundus. Option D. Insert a urinary catheter. Take a moment and think about your answer. This is a priority question. The correct answer here is option C. Let's break down why this is correct. This client is showing classic signs of postpartum hemorrhage, and the most important clue is the boggy uterus. Postpartum hemorrhage is defined as greater than 500 milliliters blood loss after vaginal birth, greater than 1,000 milliliters after cesarean birth. A boggy uterus means uterine atony, and uterine atony is the most common cause of postpartum hemorrhage. So before anything else, you need to correct the cause. Fundal massage stimulates uterine contraction. It helps compress the uterine blood vessels and reduce bleeding immediately. This is the fastest and most effective first intervention. Now let's go through the other options. Option A. Notify the provider. Important, but not first. You must act immediately to control bleeding before calling. Option B. Administer oxytocin. This is appropriate treatment, but it comes after fundal massage. Massage is faster and can be done immediately at the bedside. Option D. Insert a urinary catheter. A full bladder can displace the uterus and worsen bleeding. But again, this is not the first step. Here's your NCLEX alert. Boggy uterus equals uterine atony until proven otherwise, and the first action is always fundal massage. Then you move to medications like oxytocin, IV fluids, emptying the bladder, and notifying the provider. Now let's add a deeper exam concept. You should always think of the 4 T's of postpartum hemorrhage. Tone, which is uterine atony and the most common cause. Trauma, such as lacerations or uterine rupture. Tissue, like retained placenta. And thrombin, which refers to clotting disorders. So the key takeaway here is this. Postpartum hemorrhage is most commonly caused by uterine atony, and when the uterus is boggy, the priority intervention is immediate fundal massage to restore uterine tone and reduce bleeding, before moving on to medications and provider notification. And recognizing this pattern quickly is essential for both exam success and patient safety. Now let's move forward as we complete this section on obstetric emergencies. Question 26. Select all that apply. All right, let's break this down. During labor, a client suddenly develops acute respiratory distress and becomes cyanotic shortly after rupture of membranes, and the fetal monitor shows sudden fetal distress. This is a classic high-risk obstetric emergency scenario. And the question is asking, which findings would the nurse expect to observe with amniotic fluid embolism? Let's look at the options. Sudden hypotension, respiratory distress and dyspnea, seizures or altered level of consciousness, chest pain and cyanosis, gradual increase in blood pressure, disseminated intravascular coagulation. Take a moment and think about your answer. Remember, this is SAT, so multiple answers are correct. The correct answers here are sudden hypotension, respiratory distress and dyspnea, seizures or altered level of consciousness, chest pain and cyanosis, disseminated intravascular coagulation. Let's break down the clinical reasoning. Amniotic fluid embolism occurs when amniotic fluid enters the maternal circulation, triggering a severe inflammatory and anaphylactoid reaction. This rapidly leads to pulmonary vasospasm, severe hypoxia, cardiovascular collapse, and coagulopathy in the form of DIC. This is a rare but often fatal emergency requiring immediate resuscitation and rapid delivery. Now, let's go through each option. Sudden hypotension. This is correct. There is cardiovascular collapse due to massive pulmonary vasoconstriction and right-sided heart failure. Respiratory distress and dyspnea. Also correct. This is typically the first sign. The client suddenly develops respiratory failure due to pulmonary obstruction and hypoxia. Seizures or altered level of consciousness. Correct. Severe hypoxia affects the brain, leading to confusion, decreased consciousness, or seizures. Chest pain and cyanosis. Correct. These are signs of acute hypoxia and impaired oxygenation. Gradual increase in blood pressure. Incorrect. AFE causes sudden hypotension, not hypertension. Disseminated intravascular coagulation, or DIC. Correct. Amniotic fluid activates the clotting cascade, leading to widespread clotting followed by severe bleeding. Here's your NCLEX alert. Think of AFE as a sudden triad: respiratory distress, cardiovascular collapse, disseminated intravascular coagulation. Now let's strengthen your clinical thinking. AFE questions almost always present as a sudden collapse scenario. If a laboring client suddenly develops respiratory distress, hypotension, cyanosis, and fetal distress, the exam is testing amniotic fluid embolism. Timing is a major clue. It typically occurs during labor, during delivery, or immediately after rupture of membranes. And here's a high-yield memory tip. Think: lungs first, bleeding later. First, pulmonary collapse with hypoxia and hypotension. Then, progression to coagulopathy and DIC. So the key takeaway here is this: amniotic fluid embolism presents with sudden respiratory distress, hypotension, neurologic changes, and later coagulopathy. And recognizing this rapid progression from pulmonary collapse to DIC is critical for identifying this life-threatening condition on the NCLEX. Alright, that brings us to the end of Section 4, Labor Emergencies. These are some of the highest risk, time-sensitive situations you'll see on the NCLEX. The key pattern to remember is this: recognize fast, act immediately, prioritize oxygenation and circulation. Whether it's cord prolapse, shoulder dystocia, uterine rupture, postpartum hemorrhage, or amniotic fluid embolism, your role as the nurse is early recognition and rapid intervention. So take a moment, review these patterns, and make sure you can identify them quickly. Because on the exam, and in real practice, seconds matter. Now let's move forward to the next section. Section 5, Postpartum. Alright, let's shift gears into the postpartum period. This is the phase after delivery where the focus moves from labor to recovery and early complication detection. For the NCLEX, this section is all about recognizing what is normal versus what is dangerous. Your priority as a nurse is simple: monitor recovery, prevent complications, and identify early warning signs. Alright, let's start question 27. Matrix/grid. We have a client who is 8 hours postpartum after a vaginal delivery, and the nurse is performing a routine assessment using the Boo-Boo Belly framework. And the question is asking, which findings are expected and which require further evaluation? So before we jump into the answers, let's quickly understand the structure of this question. You are given multiple assessment findings, and for each one, you need to decide, is this a normal postpartum finding, or is this something concerning that needs follow-up? Let's go through each finding one by one. Fundus firm and midline at the umbilicus. This is expected. After delivery, the uterus should be firm and located at or near the umbilicus. A firm uterus means good uterine tone and a lower risk of hemorrhage. Lochia rubra with small clots. Also expected. In the first few days postpartum, bright red bleeding is normal. Small clots can occur as the uterus sheds blood and tissue. Boggy uterus above the umbilicus. This requires follow-up. A boggy uterus indicates uterine atony, which is the most common cause of postpartum hemorrhage. This is a priority finding. Saturated perineal pad within 15 minutes. This also requires follow-up. This indicates excessive bleeding and possible hemorrhage. This is not normal and requires immediate intervention. Mild breast fullness. This is expected. Breast fullness occurs as milk production begins in the early postpartum period. Now let's summarize. Expected findings: fundus firm and midline, lochia rubra with small clots, mild breast fullness. Findings that require follow-up: boggy uterus above the umbilicus, saturated pad within 15 minutes. Now, let's connect this back to your clinical framework. Postpartum assessment follows boo-boo belly-HE, breasts, uterus, bladder, bowels, lochia, episiotomy or perineum, Hohmann's sign or legs, emotion. This structured approach ensures you don't miss life-threatening complications like hemorrhage or infection. Here's your NCLEX alert. When you see postpartum bleeding, always assess the uterus first. If the uterus is boggy, think uterine atony. If the uterus is firm but bleeding continues, think trauma like lacerations. And here's a key clinical thinking point. The uterus gives you the fastest clue. Firm uterus with bleeding suggests trauma. Boggy uterus suggests atony. This distinction guides your next action immediately. So the key takeaway here is this. Using the Bubble-He framework helps you systematically assess postpartum clients, and recognizing expected findings versus red flags like a boggy uterus or excessive bleeding allows for early detection of postpartum hemorrhage and timely intervention, which is a high-yield concept on the NCLEX. Now, let's continue into the postpartum section and build on these assessment priorities. Question 28. Ordered response. All right, let's break this down. We have a postpartum teaching scenario, and the question is asking, place the stages of lochia in the correct chronological order from earliest to latest. Let's look at the options. Lochia alba, lochia rubra, lochia serosa. Take a moment and think about your answer. The correct order is lochia rubra, lochia serosa, lochia alba. Now let's break down the clinical reasoning. Lochia is the vaginal discharge after childbirth. It contains blood, tissue, and debris as the uterus heals and returns to its normal size, and it follows a very predictable progression. Let's go through each stage. Lochia rubra, first stage. This occurs in the first 1 to 3 days postpartum. It is bright red because it contains mostly blood and decidual tissue. Small clots may be present, which can be normal early on. Lochia serosa, second stage. This occurs around days 4 to 10. The discharge becomes pink or brown. This reflects decreased blood and increased serum and white blood cells. Lochia alba, final stage. This begins around day 10 and can last up to 6 weeks postpartum. The discharge becomes yellow or white. It mainly consists of leukocytes and mucus as healing continues. Here's your NCLEX alert. If lochia returns to bright red after progressing to serosa or alba, that is abnormal. This may indicate postpartum hemorrhage, retained placental fragments, or subinvolution, and it must be reported. Now, let's strengthen your clinical thinking. When assessing lochia, always evaluate 3 things. First, color progression, rubra to serosa to alba. Second, amount. Bleeding should gradually decrease over time. Heavy bleeding or rapid pad saturation is not normal. Third, odor and clots. Normal lochia has a mild, menstrual-like odor. Small clots can be expected early, but large clots, foul odor, or sudden increase in bleeding are red flags. So the key takeaway here is this. Lochia follows a predictable progression from rubra to serosa to alba, and recognizing this timeline along with changes in amount, color, and odor helps nurses quickly identify normal recovery versus complications like hemorrhage or infection on the NCLEX. Now let's continue building on postpartum assessment and care. Question 29. Select all that apply. All right, let's break this down. We have a client who is 4 days postpartum after a vaginal delivery. She is reporting increasing lower abdominal discomfort and fatigue. And the question is asking, which assessment findings would most strongly support a diagnosis of postpartum endometritis? Let's look at the options. Temperature of 38.5 degrees Celsius, foul-smelling lochia, uterine tenderness during palpation, lochia serosa with mild fleshy odor, mild breast fullness, blood pressure 138/86 millimeters of mercury. Take a moment and think about your answer. Remember, this is SATA. The correct answers here are temperature of 38.5 degrees Celsius, foul-smelling lochia, uterine tenderness during palpation. Now let's break down the clinical reasoning. Endometritis is an infection of the uterine lining. It most commonly occurs within the first week postpartum, especially between days 2 to 5. It happens when bacteria ascend from the vagina into the uterus during or after delivery. And here's the key concept. Endometritis presents as a symptom cluster, not just one finding. You are looking for fever, uterine tenderness, foul-smelling lochia. Let's go through each correct option. Temperature of 38.5 degrees Celsius. This is correct. A postpartum temperature of 38 degrees Celsius or higher after the first 24 hours strongly suggests infection. Foul-smelling lochia. Also correct. Normal lochia has a mild menstrual-like odor. A foul odor is a red flag for infection. Uterine tenderness. Correct. Inflammation of the uterine lining causes pain when the uterus is palpated. Now, let's look at the incorrect options. Lochia serosa with mild fleshy odor. This is normal. Around day 4 postpartum, lochia should transition to serosa and have a mild odor. Mild breast fullness. Also normal. This occurs as milk production begins. It is not related to uterine infection. Blood pressure 138/86. This is not a key indicator of infection. It does not support a diagnosis of endometritis. Here's your NCLEX alert. Any postpartum fever after the first 24 hours should be investigated for infection. Do not ignore it. Now let's strengthen your clinical thinking. Endometritis questions are pattern-based. If you see fever, uterine pain, foul-smelling lochia, think infection of the uterus immediately. And here's a key exam tip. Do not confuse normal postpartum findings with infection. Lochia serosa and breast fullness are expected changes. You need multiple red flags together to confirm infection. So the key takeaway here is this. Postpartum endometritis is identified by a cluster of fever, uterine tenderness, and foul-smelling lochia. And recognizing this pattern while distinguishing it from normal postpartum changes is essential for answering NCLEX questions accurately and ensuring early detection of infection in clinical practice. Now let's move to the next one. Question 30. NGN bow tie. All right, let's break this down. We have a client who is 2 weeks postpartum, presenting with persistent sadness, difficulty sleeping, feeling overwhelmed and unable to care for the newborn, decreased interest in usual activities, and the nurse recognizes this as postpartum depression. Now, this is a bow tie question, so before we jump into answers, let's clearly understand the 3 parts. On the left side, you are identifying risk factors. In the center, you confirm the priority condition. And on the right side, you choose the priority nursing actions. Let's start with the left side, risk factors. The correct answers are history of depression or anxiety, lack of social support. These are the strongest predictors of postpartum depression. A prior mental health history significantly increases risk, and lack of support makes coping more difficult during the postpartum period. Now the center. The priority condition is postpartum depression. This is not baby blues. The symptoms are persistent, severe, and interfering with daily functioning. Now the right side, priority nursing actions. The correct answers are: assess the client for thoughts of self-harm or harm to the infant, refer the client for mental health evaluation and treatment. Safety always comes first. You must assess for suicidal ideation or risk to the infant, and then ensure appropriate referral for treatment, which may include therapy or medication. Now, let's break down the clinical reasoning. Postpartum depression is a serious mood disorder that occurs weeks to months after childbirth. Unlike baby blues, which resolve within 1 to 2 weeks, postpartum depression persists and affects the mother's ability to function and bond with the infant. Let's quickly address the incorrect options. Infant crying frequently. This may be stressful, but it is not a primary risk factor. Breastfeeding difficulties. Again, this can contribute to stress, but it is not a key predictive risk factor. Providing reassurance that symptoms will resolve. This is unsafe. Postpartum depression does not resolve on its own and requires treatment. Encouraging delay in reporting symptoms. Also unsafe. Early intervention is critical. Here's your NCLEX alert. Postpartum mood disorders exist on a spectrum. Baby blues begin within a few days and resolve quickly. Postpartum depression lasts longer and requires treatment. Postpartum psychosis is sudden and is a psychiatric emergency. Now, let's strengthen your clinical thinking. Timing is your biggest clue. If symptoms persist beyond 2 weeks or interfere with functioning, think postpartum depression. And here's the most important priority. Always assess safety. Anytime you suspect postpartum depression, assess for suicidal thoughts or thoughts of harming the infant. So the key takeaway here is this. Postpartum depression is identified by persistent emotional symptoms that impair functioning, with key risk factors such as prior mental health history and lack of support. And the priority nursing actions are immediate safety assessment and referral for mental health care, making this a critical and high-yield topic on the NCLEX. Question 31. Multiple choice. All right, let's break this down. We have a client who is 5 days postpartum and breastfeeding. She reports pain in the left breast. And on assessment, the nurse notes localized redness and warmth, fever of 38.4 degrees Celsius, flu-like symptoms, tenderness in one area of the breast. And the question is asking, which condition should the nurse suspect? Let's look at the options. Option A, breast engorgement. Option B, mastitis. Option C, blocked milk duct. Option D, normal lactation changes. Take a moment and think about your answer. The correct answer here is option B, mastitis. Now, let's break down why this is correct. Mastitis is an infection of the breast tissue that commonly occurs in the first few weeks postpartum. It usually develops when bacteria enter through cracked nipples during breastfeeding. And here's the key. It presents with both local and systemic symptoms: localized redness, warmth, and tenderness, plus fever and flu-like symptoms. That combination is what makes mastitis stand out. Now, let's look at the other options. Option A, breast engorgement. This typically affects both breasts. It causes swelling and discomfort, but not fever or systemic illness. Option C, blocked milk duct. This can cause a localized tender lump, but it does not cause fever or flu-like symptoms. Option D, normal lactation changes. These include mild fullness or tenderness, but no redness, no fever, and no systemic symptoms. Here's your NCLEX alert. Unilateral breast pain plus fever in a breastfeeding client equals mastitis until proven otherwise. Now, let's strengthen your clinical thinking. You can differentiate breast conditions using 2 key clues: location and systemic symptoms. Engorgement is bilateral and without fever. Mastitis is unilateral with fever. Blocked duct is localized but without systemic symptoms. And here's a very important nursing point. Breastfeeding should usually continue during mastitis. Frequent feeding or pumping helps empty the breast and prevent worsening infection. So the key takeaway here is this. Mastitis is identified by unilateral breast pain with redness, warmth, and systemic symptoms such as fever and flu-like illness, and distinguishing it from engorgement or blocked ducts is a high-yield concept on the NCLEX and essential for early treatment and prevention of complications like breast abscess. And that completes this section on postpartum nursing care. Section 6. Newborn care. All right, now we move into newborn care. This section is all about recognizing what is normal in a newborn and what requires immediate action. Your priority as a nurse is simple. Support transition to life outside the womb and identify early signs of distress. Let's get into it. Question 32, multiple choice. The nurse in the neonatal intensive care unit, NICU, receives a call to prepare for the admission of a newborn born at 41 weeks gestation with APGAR scores of 1 at 1 minute and 4 at 5 minutes. Which nursing intervention should be the highest priority when preparing for this newborn's arrival? Let's look at the options. Option A. Turn on the apnea and cardiorespiratory monitors. Option B. Connect the resuscitation bag to the oxygen outlet. Option C. Prepare an intravenous line with dextrose. Option D. Set the radiant warmer temperature. Take a moment and think about your answer. The correct answer here is option B. Connect the resuscitation bag to the oxygen outlet. Now let's break down the clinical reasoning. A very low APGAR score means the newborn may not be breathing effectively, so you must immediately think ABCs: airway, breathing, circulation. The highest priority is breathing. Preparing the resuscitation bag allows for immediate positive pressure ventilation as soon as the newborn arrives. This can be life-saving. Now let's look at the other options. Option A. Turn on monitors. Important, but not priority. Monitoring does not stabilize the newborn. Option C. Prepare IV dextrose. This may be needed later, but circulation comes after airway and breathing. Option D. Set the radiant warmer. Temperature control is important, but again, not before oxygenation. Here's your NCLEX alert. APGAR scores assess 5 components. What it measures: appearance, skin color; pulse means heart rate; grimace-like reflex irritability; activity, muscle tone; respiration to note the breathing effort. Each is scored from 0 to 2 for a total of 10. A score below 7 indicates the need for intervention. A score this low means prepare for resuscitation immediately. Now let's strengthen your clinical thinking. In newborn emergencies, always default to ABC priority. If the baby is not breathing, nothing else matters. And here's a key exam insight. Preparation questions are testing anticipation. The nurse must think ahead and prepare the most life-saving intervention first. So the key takeaway here is this. A newborn with very low APGAR scores requires immediate airway and breathing support, and preparing the resuscitation bag with oxygen is the highest priority intervention, making ABC prioritization a critical concept for both the NCLEX and real-life neonatal care. Now let's continue building on newborn stabilization and assessment. Question 33. Select all that apply. All right, let's break this down. We have a newborn diagnosed with fetal alcohol syndrome, and the nurse is developing a plan of care to promote physiologic stability and feeding success. So the question is asking, which nursing interventions should be included? Let's look at the options. 1. Monitor the newborn's response to feedings and weight gain patterns. 2. Allow the newborn to establish an independent sleep-rest pattern. 3. Provide a quiet, low-stimulation environment. 4. Encourage frequent handling and stimulation by visitors. 5. Assess for vomiting, diarrhea, or poor sucking during feedings. 6. Maintain bright lighting in the nursery. 7. Provide small, frequent feedings if the newborn has difficulty feeding. Take a moment and think about your answers. Remember, this is SAT. The correct answers here are: monitor the newborn's response to feedings and weight gain patterns, provide a quiet, low-stimulation environment, assess for vomiting, diarrhea, or poor sucking during feedings, provide small, frequent feedings if feeding is difficult. Now let's break down the clinical reasoning. Fetal alcohol syndrome occurs due to prenatal alcohol exposure and affects the newborn's neurologic and developmental function. These infants commonly present with hyperirritability, poor feeding coordination, uncoordinated suck-swallow reflex, vomiting or diarrhea, poor weight gain. So your nursing priorities are clear: support feeding, monitor growth, and reduce stimulation. Let's go through the correct options. Monitor feedings and weight gain. Correct. These newborns are at high risk for poor nutrition and growth problems, so close monitoring is essential. Provide a quiet, low-stimulation environment. Correct. These infants are easily overstimulated. Reducing noise, light, and handling helps improve feeding and sleep. Assess for vomiting, diarrhea, or poor sucking. Correct. Feeding intolerance is common and must be identified early. Provide small, frequent feedings. Correct. This helps compensate for poor coordination and low tolerance for large volumes. Now let's look at the incorrect options. Allow independent sleep-rest pattern. These infants often need structured care, not completely independent patterns. Encourage frequent handling and stimulation. Incorrect. Too much stimulation increases irritability and worsens feeding. Maintain bright lighting. Incorrect. Bright environments can overstimulate the newborn. Here's your NCLEX alert. For fetal alcohol syndrome, think low stimulation, feeding support, growth monitoring. Now let's strengthen your clinical thinking. In newborn questions, always ask, does this condition affect feeding? Because feeding is one of the most critical priorities for newborn survival and development. And here's a key nursing principle: environmental control matters. A calm, quiet environment can significantly improve physiologic stability in these infants. So the key takeaway here is this: newborns with fetal alcohol syndrome require low stimulation, careful feeding support, and close monitoring of intake and growth. And recognizing these priorities is essential for both safe care and success on the NCLEX. Now let's continue building on newborn care and high-yield conditions. Question 34. NG bow tie. All right, let's break this down. We have a newborn delivered to a birthing parent with diabetes mellitus, and within the first hours after birth, the nurse identifies this infant as being at risk. So this is a classic newborn risk scenario. Now this is a bow tie question, so before jumping into answers, let's structure it. Left side, contributing risk factors. Center, priority condition. Right side, priority nursing actions. Let's start with the left side. Look at the options and think. The correct answers are birthing parent with diabetes mellitus, excess fetal insulin production after birth. These two go together. During pregnancy, maternal glucose crosses the placenta. The fetus responds by producing high levels of insulin. After birth, the glucose supply suddenly stops when the cord is clamped, but insulin remains high, and that leads to rapid hypoglycemia. Now the center. The priority condition is neonatal hypoglycemia. This is one of the most tested newborn complications. Now the right side, priority nursing actions. Take a look at the options. The correct answers are monitor the newborn's blood glucose levels, initiate early feeding as prescribed. Monitoring allows early detection, and feeding is the first-line intervention to stabilize glucose. Now let's break down the clinical reasoning. This is all about physiology. High maternal glucose during pregnancy leads to fetal hyperinsulinemia. Then after birth, glucose drops, insulin stays high, hypoglycemia. Let's quickly address the incorrect options. Delayed closure of the ductus arteriosus, not related to glucose regulation. Increased maternal glucose after cord clamping. Incorrect. The glucose supply is actually removed after birth. Brightly lit nursery. No effect on glucose levels. Delay the first feeding. This is dangerous. It increases the risk of worsening hypoglycemia. Here's your NCLEX alert. Infant of diabetic mother equals hypoglycemia until proven otherwise. Now let's strengthen your clinical thinking. Always connect the maternal condition to the newborn risk. Diabetes in the parent leads to glucose problem in the baby. And here's a high-yield exam tip. In newborn questions, feeding is often the treatment. Early feeding is not just routine care. It is a critical intervention to prevent deterioration. So the key takeaway here is this. Newborns of diabetic parents are at high risk for hypoglycemia due to persistent hyperinsulinemia after birth, and the priority nursing actions are early glucose monitoring and prompt feeding to maintain stability, making this a core NCLEX concept in newborn care. Now let's continue building on newborn complications and priorities. Question 35, matrix/grid. All right, this is our final question of this section, so let's bring everything together. We're now focusing on newborn medications and vaccines, which are all about prevention and safety. First, let's understand how to approach this matrix. You are given several statements, and for each one, you must decide, does this reflect correct understanding, or does this require further teaching? So think of this as a safety check. If the statement is accurate and safe, then correct understanding. If it contains incorrect information or unsafe practice, needs further teaching. Now let's go through each statement. Vitamin K is given to prevent newborn jaundice. This needs further teaching. Vitamin K is not for jaundice. It is given because newborns have low vitamin K levels, which puts them at risk for bleeding. It helps produce clotting factors and prevents vitamin K deficiency bleeding. Erythromycin eye ointment is applied to prevent eye infections acquired during birth. This is correct. It prevents ophthalmia neonatorum caused by exposure to bacteria like gonorrhea and chlamydia during delivery. The hepatitis B vaccine is routinely administered within the first 24 hours after birth. Correct. This is standard newborn immunization practice. If a postpartum client receives the rubella vaccine, pregnancy should be avoided for about 1 to 3 months. Correct. This is a live attenuated vaccine, so pregnancy must be avoided temporarily. The newborn's eyes should be cleaned before applying erythromycin ointment. Correct. Cleaning removes secretions and allows proper contact of the medication. The newborn's eyes should be flushed after erythromycin ointment is applied. This needs further teaching. Flushing would remove the medication and reduce its effectiveness. The erythromycin ointment should be applied directly onto the newborn's cornea. This also needs further teaching. The ointment should be placed into the conjunctival sac, not directly on the cornea. Now let's connect the clinical reasoning. Newborn medications are all about prevention. Vitamin K prevents bleeding. Erythromycin prevents infection. Hepatitis B vaccine prevents viral transmission, and maternal rubella vaccination protects future pregnancies. Here's your NCLEX alert. Always remember the core newborn meds: vitamin K injection, erythromycin eye ointment, hepatitis B vaccine, and for the mother, rubella vaccine if non-immune. Now let's anchor one high-yield concept. Vitamin K prevents bleeding, not jaundice. It supports clotting factors 2, 7, 9, and 10. This is a very common exam trap. And here's a technique tip. For erythromycin, clean first. Apply to conjunctival sac. Do not flush afterward. So the key takeaway here is this. Newborn medications are preventive interventions that require correct understanding of both purpose and administration technique, and recognizing common misconceptions, such as vitamin K preventing bleeding rather than jaundice or proper eye ointment application, is essential for safe practice and success on the NCLEX. All right, that brings us to the end of this full review. At NCLEXReviewPro, our motto, prep like a pro, let the worries go. Let's quickly zoom out and connect everything we've covered. We started with antepartum care and then high-risk pregnancy and antepartum complications, building your foundation for recognizing danger early. Then moved into intrapartum care, where timing, fetal monitoring, and decision-making become critical. From there, we stepped into labor emergencies, the highest priority scenarios where rapid recognition and immediate action save lives. Then postpartum care, where your focus shifts to recovery, hemorrhage prevention, infection, and maternal well-being. And finally, newborn care, where everything comes down to stabilization, feeding, and safe transition to life outside the womb. If you notice the pattern, the NCLEX is not testing random facts. It is testing your ability to recognize patterns, prioritize correctly, act safely. Where we don't just memorize, we think like nurses. Subscribe and visit NCLEXReviewPro.com. Sign up there, because we've got more Q&A sessions, mock exams, visual study guides, and audio overviews and plenty of high-yield quizzes. See you in next session.